Welcome and good evening, everybody from Berlin, Germany. And I'm very happy to once again say hello to all of you listening to us and watching us from all over the world. We are happy that we can continue with our format together with Dr. Chris and invite our friends and authors and family members from around the world to share with them and share with us their knowledge and ideas while we still cannot travel. And so we'd like to take this opportunity to welcome Chris, Florin, and Gustavo, I'm sorry. And it's going to be a great night of education. Chris, would you like to say hello to everybody?
Yes, hello. Nice to meet you again. And Christian, perhaps it's a good idea just to raise your glass of your gin tonic.
Yes.
You will remember all the names. And by the way, today I'm drinking a gin tonic of the Sons of Dentistry. This is very, very good and I recommend you. So welcome back. And the question is, what is aesthetics? What does it mean in the broader sense? And what is the significance of aesthetics in dentistry today? Aesthetic is the study of beauty, of the law and harmony in nature and art. In dentistry, the topic of aesthetic is becoming indispensable. None of my patients will accept a restoration that is precise and perfectly fitting, but not aesthetic. And why should he? But the overriding goal should be a restoration that combines function and beauty. And in Germany, in Austria, function has always been priority. At congresses, as a German speaker, you always had the problem that the people said function is a German problem. And no, it's not a German problem. We solve the functional problem. Remember the very now with Douglas Terry. He's one of the great dentists who combine aesthetics and function. And as you see, it's not only big in Germany, you see it in Brazil and everywhere else. And Florin, Cofar, and Gustavo, Giordani know perfectly how to restore with an aesthetic and functional approach. And I think the Smile Cloud is one of the most innovative tools to put aesthetic plannings into practice. One more word, a teaching that deals only with beautiful things is called Calistics. So welcome the Callisto dentists, Florin and Gustavo, the stage is yours.
Thank you so much.
Thank you so much for the invitation. Thank you, Christian and Chris, and everybody who's listening. It's a pleasure to be here today. Let me share my screen. All right. We're gonna make this interactive, so feel free to ask questions. We were talking earlier with Gustavo, we prefer if the questions are, at the time to answer them as they go. Mm-hmm. Instead of going all the way and then stopping and having all the questions at the end. So today we picked a case that we treated together, and the idea is to go through it and try to highlight some points as we go through the interdisciplinary part. And of course, for this, I want to, we selected a narrative. And this narrative, I think, the good one is about context. And I think it's quite often that, you get, let's say, a question like this, or you get a picture like this on WhatsApp, and somebody asks you an opinion whether, if this, for example, this case is about the paling central. As you can see here, it's an external root resorption. So imagine you get this picture and somebody asks you, where and when should an implant be placed here? Did this ever happen to you, Gustavo?
A lot. Actually, this is the way that usually we communicate, right, guys? Normally, we are not in the same place all the time. Even if you work in the same clinic, we are not in the same place all the time. As Florin says, we are only in the same time when you are going to take a picture of the clinic team, right? It's not common that we stay all the time with the patient, the whole team. And as a clinician here working in my my office, I get a lot of indications from different dentists, and usually they send this kind of documentation, like a picture, a clinical view of the case, and a tomography. And usually the question comes in an email: Gustavo, is possible to place an implant here? Can we move for immediate implant, or should we go for a late implant? And usually we have this kind of documentation, like a picture and a tomography. And if I go to the indications of the immediate implant, of course, I would check a case like that and say, okay, this is a case for immediate implant. But many other things are important, and I think Florin will discuss this.
So I think what I really want to highlight here is this idea of context. Whenever you get a question and you only get this amount of information, for example, I would be inclined to discuss, let's say, the position of this implant. The first thing that I would also notice, being not necessarily from the surgeon perspective, because I'm not a surgeon, I'm looking from the pros side, and I see, for example, that the ratios of the teeth are very square. I see it's a very deep bite. I see that the papilla ratios are small, and maybe I would be, thinking, let's say, if I am to zoom out a little bit, to, of course, try to improve these things by, let's say, crown lengthening. Clearly, if you just give me this, I would definitely tell you that, for example, there's no way you can correct, let's say, the proportion of the teeth by changing the incisal edge because of the deep bite. Okay, this is one thing. Second, you want to improve those papilla ratios if you want, and of course, it's important to discuss these things because the future implant will be placed in reference of the future crown. Now, makes sense, right, Gustavo? So if we look from this perspective.
Of course, this is, and I have this experience now because we live now in the online world for almost 2 years, and I had the opportunity of bringing my presential course to the online world. And I got many participants, and we have this like every month online discussions and also email to change experience. And I get a lot of cases like that with this kind of documentation. And all the time, the same question that I give back to the dentist is, what is the plan? Mm-hmm. What do you want to do? What the patient wants? Because if I see a case like that, and Florin is like 100% right. If Florin comes to me and said, Gustavo, is that possible to place an implant here? As I would say, Florin, for sure. But let's take the canine as our reference, and let's just do a small crown lengthening, like improving the papilla areas, improving the zenith areas.
By the way, Chris, if you're here and if there's any questions, feel free to stop us at any point. We're just gonna keep going.
Yeah.
All right.
I will say, of course, let's go. We crown lengthening. We use the new gingival margin as our reference. But the question is, what do you want to do with this patient? What the patients want? The main idea of the case.
So let me just follow up on this simple idea. Let's say that from what we see here, all we can think about is, how to mix, let's say, this concept of, crown lengthening and obviously try to be conservative. So here, let's say, most likely, if you are to see from this perspective, you're probably talking about 2 restorations. One will be the implant one, and probably the non-vital other central, right? And crown lengthening. So, and of course, you can understand exactly where to position that future margin because you have the CBCT. What we're doing today, we're just stacking data, and we are knowing all of these borders. For example, I don't really probe a case like this. It's just having the data, stacking it, and understanding where I need to place. So now, if we zoom out even more, because this is, what we are, let's say, very subtly trying to make a point here. The more we add information, the more the case tends to change. So if you're going to see, if you have the solutions, if you have, let's say, the information that we just gave you, you would have one solution. Then if you add another layer of information, in this case, it's the face. And let's say you see the picture and the video, and there's actually video is even more relevant in cases like this because it shows the freedom of expression, and usually the correct gingival display is always on video as opposed to photo. So if I'm just going to play this, you're going to see that, just by adding an extra layer of information, you dramatically can, question the plan. So this is an everyday reality. If you're planning without having a full perspective, without seeing the full info, doesn't matter. For example, you can be the surgeon, or you can be anybody in the team. In the case, I think it's always very important to be aligned and to have perspective, to see the whole story, because otherwise the plan tends to be or can be a mistake. Okay.
Yeah.
So what do we see here? Obviously, we have significant maxillary vertical excess, which in theory can make things much more complicated. Now, let's try to understand how we can play this out. So option number one, the one with crown lengthening, we can simulate it very fast for the patient. And here is what we just did. We just went and select a library and placed it, technically speaking, from the CEJ, where we can measure the CEJ to the existing incisal edge, and we virtually can render it to understand if this is appealing for our patient. And then, of course, what do you think? Do you think this is something that makes the patient happy? And that it makes the patient happier for sure. But I can tell you that clearly it's obviously not what she wants.
Yeah.
And then again, if we look more on the same information, we can notice a couple of other things. We can see these deep perinasal grooves, which always, tend to suggest that either the maxilla is in a lower position or retruded position. In this case, maxilla is, in a lower position, okay, towards where we want.
Yeah.
Then also here we can see that, especially on the video, you will see if I go back and I play the video, you will see that the buccal corridors, in theory, could be improved a little bit. And this is important as this is something to remember, just to understand why we take the certain decisions in the treatment. Then again, you will also notice something else, which could be related to our problem, which is, you can see the double chin here, and this is an interesting question, if this could potentially be improved by what we're doing as a treatment or not. And if you think about it, we are technically speaking, we are having a maxillary vertical excess, which means, and also like a entire vertical dimension excess, and which means that we have the lower jaw, imagine in this position. Because of the vertical excess, it's retruded, and in theory, if we could reduce the excess, we could benefit from an auto rotation and, technically speaking, improve that as well. Now, we are talking about two scenarios here. Scenario number one is the one in which we are crown lengthening. We are very conservative. We would do probably just 2 restorations, and we would be, biologic in terms of our decisions, but we would not nail the objective. The patient is not exactly happy with that, and this is something important. Now, on this other side, you see again the same library or the same design, just changed in terms of position very fast, virtually to understand how this would impact. And remember, we were talking, for example, about the buccal corridors. Why is this important? Because you can see in this picture, there is an intrusion effect. If we would, let's say, intrude, there's 2 ways we can compensate this. We can either do it surgically, right, Gustavo?
For sure.
Like orthognathic, or we could do it skeletally. Now, either way, there is, let's say, especially for the skeletal, there is an effect depending on the maxillary anatomy, like the maxillary centipede. So in the frontal area, if we go for intrusion, what this means? It means that the arch shape will decrease, which does it benefit us? Well, remember the deep bite. So we have also we could let's say, compensate the skeletal anomaly better. And if you think about the bone in the posterior area, the maxilla tends, so if we intrude in that area, we could potentially improve the buccal corridors because it would widen in that area.
Yeah.
Now, you are the best one to discuss about, let's say, skeletal versus mini plates. Skeletal versus orthognathic, and just explain a little bit the reasoning.
Yes. This patient came to us with the chief complaint of gummy smile. So when we saw her, we saw that we had vertical maxillary bone access. Okay, we had upper lip hypermobility, and we had short teeth, and we are going to lose one central in the middle of this conversation. So starting this conversation, like, is that the time of distraction is the best way to start? Because normally, if I just discuss about, guys, should we extract and place an implant now, or should we do later? For sure, in this case, in this patient, we need to go and do this later, because again, the chief complaint of this patient is gummy smile. And when we decided to treat her from a complex case to a simple case, then we go for extraction and implant. We have different options to first change and solve the problem of the vertical maxillary bone access. And when we have a case like that we need to impact the maxilla, as Florin said, or we do surgically, like orthognathic surgery, and as a maxillofacial surgeon, I know the benefits, the limitations, and how, let's say, not easy for the patient it is. And as a surgeon and working with mini plates and mini screws with ortho intrusion, I know, again, the limitations and the benefits of that. Every time that we just want to intrude, like vertically, we have both options, and both will work very well, because surgically you can do it, and with skeletal anchorage you can do it, because it's just vertical movement. It's like simple. Of course, with a very good ortho, you can do it very well, because when you don't have a good ortho that works with the skeletal anchorage, you can lose a lot of anchorage and you can expand a lot, then the case is going to be a mess. But when you go vertically with mini plates, you go in a, let's say, a slow step. The muscles are going together with the movement, and then the result is really nice, because we are thinking about, we are doing this like for many years. This is not new. Imagine if you lose like lower teeth. Normal, we have extrusion of the upper teeth and also the bone together. Usually we just put some mini screws or mini plates, elastics, and we just go up with the bone, and then we place implants here. In the like full maxilla is the same. Of course, we control better with the mini plates because we have more versatility. We have more anchorage. So using like 4 mini plates, as we use it in this case, we have a lot of anchorage, and doing this movement, it's really, really amazing. And as Florin said, you can just go up with the maxilla and you have an auto rotation of the lower jaw. And this is going to be very good for the patient. So in this case, you can do with a skeletal anchorage because it's only vertical, and you can do also with orthognathic. We do in this kind of case with skeletal anchorage because we see the movement like in a slow step. The muscles are going together. The patient will
just one second, just to make sure that everybody understands the reasoning here, like from the start. So the idea, you have to think of it this way. When you see a case like this and the patient, like you said, complains about the gummy smile, and you have a failing implant, okay, failing tooth, sorry, that you have to place an implant. First of all, you realize that placing an implant is going to be like a definitive solution there. So the second that you're going to place an implant there is you're going to be stuck to restore the whole case,
yes,
depending on the vertical of that implant. Now, here, the first thing that you must notice is that it's impossible to fix this case with crown lengthening alone, because it would definitely not be feasible in terms of biology. Even if you crown lengthen a lot, go beyond the CJ, even if you do that, it's still not something that is feasible. And then again, let's say if you crown lengthen and you want to do like to restore with also to change the size of the teeth, increase the size, which is again something that clearly aesthetically the patient needs to just balance the rest of the gingiva, so you don't compensate the whole gummy smile. And then you say, okay, I'm gonna increase the size of the existing teeth, so you do like full arch, let's say. Then again, you still have a problem, because imagine, first of all, you're going to need room for that when you prep. So you crown lengthen, and then you need to be very aggressive to create that space for ceramic, because remember, your problem is a vertical dimension problem. So the last thing you want to do is to open in any way. So there's no way that you want to increase in any way the vertical dimension. So then comes the other alternative, which Gustavo is talking. So what if we, instead of going, we go for the cause of the problem, which our problem is vertical dimension. Can we decrease the vertical dimension? This is the first question, because the crown lengthening is an effect of the vertical excess problems. We need to crown lengthen because we have this. So then, how can we decrease the vertical? One is orthognathic surgery. Okay, you surgically reposition the maxilla, and in theory, like you can achieve, let's say in theory, all your goals. Yes. The second one, which is the interesting one, which we're going to talk about today, we're not going to make it like a huge debate between orthognathic and skeletal, but we're just going to tell you this. Sometimes when you need to decide between the two, the patient is a very important factor. And sometimes you just need to ask the patient, hey, do you like your face? Because if you're going to do orthodontic, very likely you might need to change your ID. And in this case, what the patient told us is, I like everything except my gummy smile, right? So then we went for this idea of impaction. I'm going to move a little bit forward here because this could potentially solve a lot of our problems. We could compensate the excess gingiva. We could have an auto-rotation of the lower jaw, which also functionally would have been a benefit. Of course, we teamed up with a very good orthodontist here, Johnny Barbour, who's been working with us for years. So he is, like, what can I say? I think for me, he's one of the best.
Yeah,
Let's put it this way.
Yes.
So this is the position of the mini plates, and the idea is here. You see the three little hooks. The idea is that they will be used as anchors to impact, in this case, the entire maxilla. Okay, and the plan with the failing central is we're going to keep it for as long as it's humanly possible, because if we can keep it during the ortho, we can move structures with it, and it's going to help us achieve our goal. And at the end, ideally, we would extract, or if we do it along the way. The reason why we think like this is because it would be unrealistic to place an implant deep enough towards where we would want the whole smile to go.
Sure.
So,
just to finish this, Florin.
Guys, can I interrupt you for one second when we are at the ortho? Because there's one question from Philip Stähler. He's asking you, if you are doing ortho anyway, why not just close the gap after tooth extraction and place the implant in the premolar area instead of dealing with an implant in the aesthetic zone in a young female patient with a high smile line?
Do you mean like putting the lateral in the central place?
Yes.
I think
it is an option. So the situation where we do that is in sometimes if you have missing laterals, and sometimes you want to bring the canine to a lateral position and put the implants in premolars. And we choose to do that when it's realistic in terms of, let's say, like ortho treatment. Now, if you want to be doing that here, you would complicate the biomechanics tremendously. This is first thing. And second of all, you would probably be doubling the time of the treatment. So the pragmatic reason why I wouldn't do that is this two. Plus, actually, I've never actually done this to move a lateral to a central position for many other reasons. First of all, the root is smaller, etc.
I think aesthetically speaking, it's really not. It's going to be worse.
Challenging.
It's very challenging. Yes.
Then you have a canine in the lateral position that you have to make the root smaller. So it's just a lot of things you need to do to and you're only leveraging that you have an implant, which is, let's say, safer in the lateral area. I agree with that, but it's just too much effort on this side of the scale.
I agree.
So one thing, as we intrude, you can see here with the hooks gone as the intrusions occurs. First of all, you see what happens to the deep bite and how the vertical changes. Actually, the vertical looks as it's increasing. In reality, it's collapsing because you're having this auto-rotation. It's just that the relationship tends to look more like a class 1 now. Because as we intrude, we start to compensate the skeletal anomaly. Now, a side effect to intrusion, this is something that we learn that we always have, especially if we intrude a lot, is this flaring. So the second that you're intruding, especially like here, which is like, I don't know, 8 millimeters, 7-8 millimeters, you're always gonna end up with the teeth flaring out. Why? Because if you don't do that, you're gonna either take the roots out of the bone or you're gonna have root resorption because you're scratching the root in the cortical. Okay.
Mhm.
So this is how it's supposed to be after you intrude a lot. Now, what does that mean? It means also that whenever you intrude this much, 100% you need to know you're going to do veneers or crowns or restorative after. Why? Because the patient is never going to be happy. I mean, we're talking about patients that have high aesthetic demands, not going to be happy with this type of let's say end result. The reason why a tooth which is flared does not look good is because the reflection will always be on the bottom part of the tooth, which will always look like a PMMA, even if it's natural teeth in terms of optics. Plus, aesthetically is not ideal. Now, also, as we do this, we see that we are having a lot of excess tissue, even in the palatal area where we expected less. And here we have been using these guides for quite a while now. This is an example where we had to do also like a double guide with the windows also in the palatal, because up to this point, have you ever done a palatal crown lengthening? Up to this point, Gustavo?
No, I think it was the first time, yes.
Yeah, so imagine it's not something that you need to be guided to just be precise with this. And also look what's happening to our central. You can see you have like a more significant reaction around it, so it's closer to failing now, but it's where we want it. Yes. And at this point, if we extract it, our goal has been done. So it's very important. Again, sometimes even if you have to extract a tooth, there is sometimes a strategic decision when in the timeline can you extract. And this is what I learned also from Johnny, because okay, you see you have a hopeless tooth or a third molar sometimes or whatever, but you have to ask, can this help me along the way? Can this be helpful in any way? And then in this particular scenario, you choose to keep it in place until everything is done, and then you can do this. You want to comment a little bit about the crown lengthening, or should I?
Sure. We usually do this kind of guide. It's just a strategy combining the CBCT and the scan of the patient. We just check exactly the CJ. And for us, the best way to cut the soft tissue is using the electrosurge. I try many instruments to do that, like normal blade, micro.
Normal blade does not work with this guide because it's not practical. You cannot go around the curve. So this, I think, should be called an electrosurge guide, because this is how it works really well.
I agree. And also using laser for that, it's really difficult. The cut is not perfect. So using the electrosurge, the clear view is amazing. You cut perfectly. Using the guides, you can have the perfect CJ reference. So you can cut perfectly. Every time that you want to go for aesthetic rehabilitation, using the shapes as our guide, all the time we move to guide the surgeries, not only for implants, but also for crown lengthening. This is really important. And I mean, of course, we are doing palatal here, so our reference is the CJ, but every time that we crown lengthen in the buccal area, we always do we use the reference of the future restoration. So using the shapes that we selected from Smile Cloud, we just superimpose with the actual STL.
You want to share a screen for this part? Maybe?
Yeah.
Because you have.
Sure. And we are here. Here. So this is our patient now after ortho. Just to
this is the new mock-up, right?
Yeah.
So it's the same shapes, that we did in the beginning virtually, we turn this into like a printed model, and we do a mock-up on the new situation, respecting the initial promise that we did to the patient. Exactly. And with some paint composite here and some tricks, but it's just following up on our initial proposition.
Actually, Florin says all the time, and I agree, we change a complex case to a simple case, but we always follow the shape. This is the most important thing. So the first mock-up we do is the shape that we are going to like following all the treatment, like the guides of the soft tissue, the guide for ortho, the guide for implant. Everything is related to this shape. But the first mock-up we did this shape using pin composite, so the patient can see. We motivate the patient, and then we start the ortho intrusion. Then we did the ortho. This is the patient after ortho with the new mock-up, but not with composite anymore, because now the bone and the soft tissue is in the correct position. And then we just need to plan our extraction and our implant. So this is the patient with the new mock-up. This will guide all the guides we need now. So you can see the patient now in the left side after ortho. You see how we changed the face of the patient, but in a very soft way, very gentle way. I mean, we had this auto rotation of the lower jaw. Now the patient is happy, and we just solved the problem with the vertical maxillary bone axis. Now it's time to take care of the pink and the final restoration. So what now I'm going to check if it's a case for immediate implant or not. Now I'm going to check the bone, if I have a residual bone to place the implant, because in the beginning it was just a discussion if it's possible or not, but related to the face was not. So that's why we kept the tooth to do this intrusion, and now it's time to check the bone. Bone is okay, soft tissue is okay. If I don't have bone enough to place the implant now, I will go for a socket preservation, extract the tooth, place the biomaterial, do connective tissue graft, wait 4-5 months, and then place a late implant. But now I have bone, I have the soft tissue in position. Of course, I have some problems like infection. I have some problems with no buccal bone, but this is not a contraindication. I'm going to manage this during the surgery. So now what I need to go and move for the implant, I just need from Florin the DICOM file, the STL file of the actual situation, and the STL of the mockup, the shapes that I have. So then we go to the software, we plan the implant position, and we start to select our prosthetic components. And this is something that we do all the time, because guided surgery or virtual planning is not only about the implant position, but also the selection of the prosthetic component. And we decided to use a nice tool, which is the Connect. It's a transmucosal prosthetic component to keep the bone there, and we select the height, everything is there. As Florin showed you guys, the double...
Just like you can customize your implant, basically.
Exactly. And this is something that when you go in an analogical situation, let's say, it's really difficult to select perfectly your prosthetic components when you touch the bone or not. You need to create a big stock. So when you go in this virtual world, it's nice to check everything that you need. We did our crown lengthening, again, using the same files, CVCT, STL of the mockup. We cut with the electrosearch, use the CJ as a reference, and then we start our implant. And then we just need to follow all the biological concepts and the future restoration. So I'm just going to play some videos so you can enjoy the step-by-step of the surgery. You can see that we have a lot of tissue, and then we are going to take care of this. We don't have bone in the buccal plate. We have a very thin soft tissue. So now it's time to take care of everything. We are going to do a frenectomy. We are going to place the implant. We are going to support the tissue in a digital way. So we always start in a very delicate extraction, cleaning everything very well. Of course, we had infection, so we started using antibiotics in the 1 week before the surgery. We tried a guide. We use M-Guide from MIS. It's a very nice system to do that. Very clean, very easy to use, and very trustable, let's say like that. So we are checking the guide after the extraction, and we are placing here a 3.9 millimeter implant. I like a lot this guide because the clear view is really amazing. You can check the passive fit very well, and it's a 100% guided system. And this is something that I really fight in here in my clinic with the companies, because I tried like many different guided systems, and you don't have like 100% guided system in all the brands, because you sometimes drill everything very well with the guide, and then you have problems to place the implant with the guide, and then you need to remove the guide, or you are not 100% guide, and you have like different steps and difficult steps using the reductions spoons. It's really not easy to do. With this system, it's easy. You just hold the guide, drill very well. You don't need to remove the guide. You don't need to use fixations points. It's really, really easy. And again, it's 100% guide, because you drill using the guide and you place the implant using the guide. In my opinion, it doesn't make any sense to drill with the guide and then remove the guide to place the implant. So 100% guided system is a guide system that allows you to place the implant, and the implant doesn't touch the bone before the insertion tools touch the sleeve, the metal sleeve. So now I have 100% guided system, and then I just go in and place the implant perfectly related to the final restoration. And that is the most important thing. The conversation about the final restoration and the implant placement. Something that was like almost impossible to do in the beginning of the treatment, because the vertical, the difference in vertical position was like too big, and then it's not possible, but now it is. And then we just improve it here, the papilla area. Florin, can you comment?
Yes. First of all, there is a question: why not forced eruption of 11 for implant site development? There's no need. We already have, keep in mind that in terms of bone, there's enough bone for stability. And second is tissue. Now, a side effect of the extrusion is all the excess tissue. So you will notice that we have a lot of tissue, which we are just managing. She's in her 30s, the girl, the patient, 30-ish. Don't know the exact, but it's...
I think she has like 33, something like that. Right?
Yeah, something like that. So no, not really worried with I mean, it's manageable. It's manageable, this idea. Now, let me go back to the point I want to make. You see, right now we have all of this tissue, and it just doesn't shape up to like a proper papilla. So the idea that we had here is just take a burr and a disc and just go and create like the triangle beneath the contact area. So you have to do it under the contact area in order that will allow for this tissue to properly be modeled how we want it. Remember that always it's existing dentition / new restorative that works as a scaffold for healing.
Yes. So after that, we just proceed with our step-by-step surgery.
There's another question. Any concerns about root resorption, excessive blunting with intrusion? So root resorption is always a side effect, which you always have to take into account and always have to accept the risk. But this is being leveraged against orthodontic surgery. And this is something that you discuss with the patient and you inform. You have this risk here, you have this solution here, this, and you take the decision together with the patient. Root resorption technically happens when you're scratching the root against the cortical / going outside of the bone. So technically speaking, there's a way to manage that. If you're planning specifically, if you're planning using CBCT.
Yes.
Go ahead, Gustavo.
Just removed, no problem. We removed the frenulum, doing a very simple frenectomy. You can do the same at the same time of your implant placement and also the tissue reconstruction, no problem. You just need to detach a little bit the tissue there, sutures to close the frenectomy, and then we move to the aesthetic tissue reconstruction. Very important step, because we know how important it is to have rigid support for the soft tissue. We know how thin normally is the buccal plate, and we know that we usually have from the literature from like many years, we usually need more than 1.1 millimeter of buccal bone. That's why it's super important to create this rigid support for the soft tissue using biomaterial. We always fill the gap with the biomaterial. We like to use a lot biomaterial to pack. There, we don't need to use membranes if we have just fenestration, or if we lose not 100% of the buccal wall. We just use membranes when we lose like 100% of the buccal wall. So normally we just use biomaterial and connective tissue graft. This is a formula that we know from many years that works very well and brings us stability. So usually 100% of our case is an implant in the palatal area. We create a gap between 2 to 3 millimeter. We pack biomaterial. We fill that with connective tissue graft, because we really want to have tissue thickness to create stability, to create bone stability. We have many papers showing us that we need tissue thickness to create stability in a long term. I'm not going too deep on this, but also not only for tissue stability, but to block the color of the restorative material that we are going to use, we need more than 2 to 3 millimeter to block the color of the zirconia and the ceramic that we are going to use to create, again, a very nice aesthetic results, to bring tissue to Florin, to manage all the emergence profile, to prevent recession in the long term, to grieve bone stability. And we like to use very simple techniques for that. We always try to use autogenous soft tissue in the aesthetic area. I think is the best option. We have like nice materials like soft tissue substitutes, but in aesthetic area, in my opinion, I still use the autogenous graft. The result and the stability is really good, and it's super comfortable for the patient using these superficial techniques like free gingival graft, utilized simple technique that brings comfort and a very nice soft tissue for, again, bone stability and aesthetics. So one suture, very easy. We just bring this tissue, a lot of fibrous, very good lamina propria graft, and we just need to create a pouch and stabilize with 2 sutures. We always, as much as we can, avoid to open flaps in this kind of case. I mean, we just did a very nice ortho treatment. We are trying to put all the details in this case. We are creating space for the papilla. I'm not going to be crazy like to open a huge flap and trying to reconstruct in a easy
Remember
way.
that we haven't done any flaps in this case.
This is something
Zero.
really nice.
The crown lengthening also we did like flapless, the bone reduction using like an ultrasonic tip. So there has been like zero flap.
I agree, and we try as much as we can not to open flaps. We know the result after open flaps, we always lose a bit. So of course, whenever it's possible to go flapless, we go. And we have instruments and materials for that, like microblades. We have the piezo for the crown lengthening, so we can do nowadays very easy flapless procedure. So now we have implant, biomaterial, connective tissue graft, and again, as I said, we use this connect, which is in my opinion a nice tool to avoid connections and disconnections inside the bone. So we take the platform away from the bone, because as we place the implant 4 millimeters difference, 4 millimeters deep compared with the gingival margin, the future gingival margin, we usually are inside the bone with the implant. We are subcrestal. So using this connect tool, we just bring the platform outside of the bone. So every time that we go into connect and disconnect, we are not going to connect and disconnect inside the bone. So the topic here is to create stability by increasing the tissue, placing the implant in the correct position, using these prosthetic tools to avoid connections and disconnections inside and bring stability there. After that, we just need to support the soft tissue. We go, we put a scan body, we take a scan of the patient, and then we go to the lab to mill the provision using PMMA. This is nice and easy because you can take from the tomography the adjacent teeth, the adjacent tooth. You can just copy the critical contour of the adjacent tooth, and then we just design perfectly in the critical contour the same design of the adjacent tooth, the tooth number 21. So you have the critical contour exactly the same of the contralateral tooth, and then you just do a subcontour to bring space for the tissue thickness increase, and then you finish in a very easy and fast way. We know how important it is to have a very nice provisional to support the tissue and to bring, let's say, a prosthetic.
This is also very important to say, this is like a transitional provisional, because you cannot have the final shape because you need to change the shape of the other teeth. But you can have the final transmucosal design, which means here you have the transmucosal that you're not going to change for your final, but you have the transitional coronal part, which is going to stay in the healing of this stage.
That is the point. And as you can see here, after 4 months, you see the increase, papilla area will increase a lot. We open the space, like bringing volume for the tissue, put the contact points in the correct position, and then the tissue just go and fill the space. You see after 4 months that you can create a very nice papilla and a nice volume. So now Florin can move on and finish the case. Do you want to share your screen, Florin, or should I continue here?
Oh, yeah, sure. Let me see this question. Always leads to tissue excess eventually. I thought opening a flap is indicated because of the horizontal component. Yes and no. It really depends. I mean, you can take a CT.
Which is the question, Florin, just to understand?
Yes. Go to the chat while I share my screen.
I'm here. How deep you place the implant? Do you already answer this one, Florin? How deep you place the implant?
No, I didn't.
The question now is, I have a question for both of you. Do you feel like you can, post-ortho intrusion that always leads to tissue excess, actually get a predictable, very important, flapless bone reduction? I thought opening a flap was indicated because of the horizontal component of the bone. That's the question from Giuseppe.
Yes, and the answer to that is that can only be a problem in the molar area, because that's the only area where you're going to have bulky bone as you intrude. In the anterior area, you're moving the root towards the thinner part of the crest, so eventually the bone thins out as part of the process, which means pretty much it becomes a candidate for flapless in most cases. Nothing is 100%, but there's a general rule. This is what happens, and of course you can always validate that with a CBCT by the time that the ortho is pretty much in check. So when you think that you are, done with the ortho, you take a CT and then you check the bone. And if you have like 1.5 millimeter-ish, you can go flapless. Anything more than that, then it's indication for a flap. But the idea here was we try to avoid the flap because we wanted to keep these beautiful papillas that we gain from the intrusion, which otherwise, if we would open a flap, we would lose them again. Because otherwise we would have, it really factors a lot in the final aesthetics. You want an 11 millimeter central here, and it's a huge difference if you're going to have a 2 millimeter papilla or a 5 millimeter papilla, and the flap would definitely gonna bring us down from that part. So
just answering this, Florin, a question about the depth of the implant. We always take the buccal, the future gingival margin as our reference, okay? We don't take in consideration the bone. We take in consideration the future gingival margin of the future restoration. So our STL will be the guide, and we place the implant 4 millimeter deeper compared with the future gingival margin.
I have also something to mention here as a prosthodontist. We know that, it's always 3, 4, or 5, depending on who you ask, you'd get this answer that the implant is going to be 3, 4, or 5 millimeters from the future gingival margin deeper, And here, the most important thing is how palatal is the implant. Because if you're going to have a very palatal implant, 3 is never going to be enough, and sometimes not even 4, because you will end up with like a flat emergence profile, and there's no way you can, manage that prosthetically in a nice way. So always the answer is not absolute. The answer always has to factor the palatal position of the implant. If your implant is very palatal, it's always going to be deeper than if it's not. So the answer is either 3 or 4 or 5, depending on how palatal the implant is.
Perfect. Let's say like ideal position of your implant
is 4.
It's 4. That is it.
Yes. 5 can be too much, and 3 is always no room. Is always 0 room for error for the prosthodontist. The surgeon will always be happy, but as a prosthodontist, you can suffer with 3 because you might not be able to achieve your design, your initial, So now at this point, this is something very interesting that we did here is we actually used, again, very well, we stress a lot this idea of using biometrics, which is patient-specific data. We start like with shapes of teeth and libraries and all that. And this is another example of using like motion, which is patient-specific. So there are a few key things here. First of all, you're able to do these recordings in a physiological way when the patient is not numb, or you're not tired, or you do this just before everything. And basically it's a technology that captures all the functional movement. And by having a recording which relates also to the position of you basically have a tiara on the head of the patient, which means if you have the relationship of the maxilla with the tiara, you have a face bow, and then you have all the functional movements that you're recording. So you have more than a digital articulator because you have the pure motion, and because you have also the condyles in the recording, you have like condylograph. So it's a very nice tool whenever you do cases like this. This is Mojo, a French company that we have been working with in cases like this. So this is an example where, again, you can take this, and here I took an example of actually chewing, and here you can see the chewing pattern of the patient. And remember that we collapsed the vertical with the intrusions. We got a little on auto rotation, but now I also, as I want to do the restorative, I need to again open a little bit of it, so I'm not very aggressive in the preps. And now I can take all of this information in the design process, which works very simple, like Mojo can export like an XML file, which has the coordinates in space of the scans. And you can see it integrates with softwares like Exocad. And here you can see, for example, the patient chewing pattern that we have from one vertical, which is embedded in the design of the patient in the newer vertical, which again is higher here. It's actually lower than the original one because of the impaction, but here I leveraged a little bit of that space that we collapsed to reduce the amount that I would need to prep. And this is, of course, the original library in position. Now here, I don't want to go very much in detail. We are pretty much running out of time. But when you prep for CAD/CAM, there's like two ways that you can prep. Either you go uniform prep, like you see the central, the upper central here in the example. Either you go for a gradient prep, which is the lower one. They both work. The one mistake which you shouldn't do is, for example, sometimes you always have to factor in the shape that you're using, okay? Because if you use a prep guide, you should always have, wax up or design or whatever that guides your prep. And sometimes you can see the mistake when let's say, especially when sometimes you're using natural shapes, they tend to be more flat than wax ups. And then if you prep like we used to do in the analog way, which is very accentuated in 3 planes, you might end up with a scenario where you have the thinnest area of the restoration in the middle, which means whenever you see restorations that are yellow in the middle, that's a prep mistake. And then also in that scenario, you will have like the white will be in the cervical area, which is again opposite of what we want because there's too much thickness there, because that's the way it has been prepped. It's just, like a detail here. So the idea is, again, either uniform or gradient, thinner in the cervical, and then you increase as you move towards the middle third. So again, we went here for restorations of, this is Empress CAD Multi. Just one comment regarding the material, because again, we work with monolithic for a simple reason. When we have these elaborate plans, is the one guarantee that whatever we design will end up in a final plan. That's the reason for monolithic, which is a huge reason, because it's not only the ability to copy a natural shape, which is very nice, but it's also the ability to copy a very accurate plan. If you again have to do like post milling and analog steps at the end, you lose a lot of that planning. And one thing which is important in monolithic materials, although we have 50,000 materials, the ones that really matter for me aesthetically is a handful. And here it's because of a simple rule. In analog, you can take any material, and in the lab process, you can increase its value because you have layering, right? Now, when you work monolithic, which means you're not going to be using layering, anything you do to a material will only bring the value down, which means you naturally have to be biased towards high value material when you're working with monolithic. And this is an example here, Empress CAD Multi. And also on the implant, it's a like hybrid design where you have a screw hole going through both the crown and the abutment, and they're bonded together. So this is the change that you see in the patient. So technically speaking, you can see that we use the ortho to collapse, okay, to collapse the vertical, by which I think we harmonize the face in a less invasive way than if we would have done orthodontic surgery. You always have to consider the alternative, okay? What would have been the alternative? Orthodontic surgery, which means you lose a lot of the facial identity of the patient, more invasive. And many times, again, sometimes I'm not arguing this is not a universal thing. This is a very case-specific argument. And then again, we compensated the skeletal part. And here, once again, I have to mention that the real brilliant part, the hard carry of this case was Johnny, orthodontist, that again, it's really not easy to pull off this a case like this without having any side effects. And we technically didn't even have side effects. And also he managed to take like a damaged root throughout the whole treatment and to get us to a good situation. And also in this picture, what you're seeing is the original vertical and deep bite, and on the right hand side you see the new vertical. Well, in reality, facially, the vertical on the right hand side is actually lower than the one on the left hand side. It's just because we shifted the whole vertical excess from a gingival point to having it space for ceramics via the ortho. So this is as we go through the steps, and here you can see as we go to the final. So this is like in terms of ceramics, again, it's very simple. You just not very simple. I'm trivializing a little bit, but the concept is simple. You take the library, you stick to the library, and then monolithic material, manage the substrate if that is the case, not the case here. And we get to, I think, a nice result. All right, so let me just check. There are some questions.
Yes, I have a question to you, both of you. This was an absolutely fascinating case. And my question is, where did you treat this? Was it in Sao Paulo or?
No, in Romania.
Yeah.
And how do you do that together? Because Gustavo, you sit in Sao Paulo, you go from one city to the next. You always work this in a team, or how do you go on with these cases?
This is just exceptional that we work every now and then when we happen to be on the same continent. It's not something that we can do on a day-by-day basis, of course, because we are separated by a huge ocean. But we are great friends for a lot of years, so whenever we have the chance to do something together, we try to do.
Oh, that's great. That really, I think this makes fun to work together, and you combine all the knowledge of many people. That's great. There's a question from Nitzan Minchacho, which is very nice that he's watching this webinar.
Yes.
Gustavo,
hello, Nitzan.
And he's asking,
Gustavo, this is for you.
Yeah, the question is, the implant platform is 4 millimeter or the Connect platform?
We usually take as in consideration the head of the implant. We usually place the implant like 4 millimeter, and we select a Connect like 1.5 millimeter just to bring the platform outside of the bone. So if you need to place the implant a little bit deep, because you need like to create a better anchorage of your implant. And then we can just put the implant like 5 millimeter and select a Connect of 2 millimeters, something like that. But usually we take as in consideration just 4 millimeters of the future gingival margin and the head of the implant, and then a Connect, bring the platform outside of the bone about 1.5, so we can still have like 2.5 millimeters to work with the provisional and the ceramic material. But
this Connect platform was only for the provisional. At the end, you did not have this Connect platform anymore?
No, it stays forever.
Okay.
You just place the implant, you put the Connect, you torque it down, and then you don't remove anymore.
Okay.
The main point of this Connect is like to torque it down and to bring a very stable connection inside the bone. So it's a platform shifting connection, it's con-Morse connection, and then outside of the bone, you start to play with your provisional cylinder, you start to play with your tie base and everything that you need. But every time that you connect and disconnect the micro gaps of the component, the prosthetic component, it's outside of the bone with a lot of soft tissue around. So the inflammations that you create there, it's not going to touch the bone anymore. So it's nice component for stability of the bone.
And your definite abutment was zirconia based.
Yeah.
Yeah. Now there's a question from me. When we started our webinars, we had a blockbuster of 4 webinars about the implant long-term success. And the last part of this was about the maintenance care. And we were discussing about when you have a zirconia abutment, on the long-term run, do you let your patient go down under the gingiva to floss it, or do you stay away because it's zirconia? This is a biological problem, and everybody gives me another answer to this. You know, in former days, we were always teaching all the people to floss down a little bit to the sulcus, and when this popped up that zirconia can get a little attachment to the gingiva, we started to stop this, but actually we don't know what is the truth. What is your opinion to that?
It's a very good question, Chris. I never thought about. I always teach my patients to floss inside the sulcus. I actually don't know the right and the perfect question. I usually ask the patients to floss normally and go in, but it will be very nice to see the studies that we don't need to do that. But actually, you teach the same, right, Florin?
Yes.
You know,
I mean, I just I'm not sure that I got the question. Is how does the hygiene in the implant area?
The problems, and I have very much debate with my dental hygienist in my office. You know, no, in former days we teach everyone who gets implants from us that you use special floss and you floss the abutment, the upper part of the abutment, and you go a little bit under the peri-implant gingiva. But when we saw all these new materials and we saw the histological and biological means of zirconia, we know that you get perhaps a little bit reattachment of your peri-implant tissue to the zirconia abutment. So the question I have, does it make sense to go down and floss under the gingiva or the mucosa, because you could destroy this? And there's this, you know, in every webinar we ask the speakers, and everybody has a different answer to this.
Well, short story, I don't know. If you ask me, I will tell you just my common sense tells me. First of all, whenever it's anything implant restoration, I think what we should advise is that the patient should do it in a gentle way. This is common sense. And the second thing is, which I think it's a nice way to just not worry about this at all, is to advertise the use of water picks, which is what we normally do. Is we always, try to get them to use in their maintenance the water jet around, especially around the implants. So instead, as an alternative to flossing. But it's an interesting point. But again, I just think that the solution is to be common sense and be reasonable in the hygiene process, and that's it.
Yeah.
Okay. There's a question from Douglas Terry, who's also watching us.
Another master.
Yeah, one of the big masters. He's a very nice case. And did you use the injection composite technique for initial provisional after ortho?
Well, what we use for provisional is meal PMMA. As you know, you have to be really skilled to be using the injectable technique. I think for me, it's much more easy to meal PMMA because it's just easier. But for sure, it's a good alternative. It could be an alternative even for finals in cases like this when you want to delay. But what I use, for example, when I use the injected, technique is which is for the ones that don't know, Douglas is probably the one that invented it. I adapted to blocking substrate. So if I need to rebuild an abutment, this technique is perfect because I can block, let's say, a metal post and have control over the thickness. And there's a third advantage. I don't have to worry about the contact points, which is the difficult thing in the technique.
Yes, I absolutely agree, because I think you said you made a scan after you placed the implant, and
yes.
I think it took a long time till to get the provisional out of your lab. So the big difference is, for example, in my office, I don't have a lab directly here in my office.
Yeah.
If I scan it, it takes time, and I gave a lecture in Sylt, and we use this injection technique because if you're alone, you have your cast, and you can place your implant, and you put it on a provisional cylinder, and you put the flow injection technique, and you have the perfect provisional made in
for sure
15 minutes. So it's a great opportunity for all those who are not able to mill this with your lab in between the next 1 or 2 hours.
And also, Chris, what I do here in Brazil, and I don't have a lab together with me, I do what we do, the same design. We mill provisional in the lab, and then I ask the lab to bring me everything with 2 wings. And then I just, with flowable composite, I just capture inside the mouth, just finish the subcritical contour, and that's it. Another option that works very well.
Now there's an interesting question. It came up already 1 hour ago. It's from Hatham, and he asked, how old is that girl, and is there any problem with the late growth? So do you think something can pop up in the future that the teeth go apart or something like that? Do you think this could happen? I think there's
always risks to any alternative. Yeah. But the risks are, I think, are very well weighted in this case. The patient is in around 30-ish. Gustavo says 33. I don't remember right now, but it's in the 30s, mid 30s. But then again, like I said, whenever you leverage risks, you have to leverage the risks of the procedure you're doing and of the alternative procedure that you can have. Yeah. And if we are leveraging the risks of, let's say, passive growth with all the risks associated to orthodontic, is just, I think, more manageable on this side if we put, the whole things. Plus, it's like Gustavo was saying, it's a gradual way to treat, and I think it's also very important as an outcome that we preserve more identity. Remember that the patient was happy with her face.
Chris, I don't know if you're talking about also the implant.
Yeah, for sure he's talking about the implant, but that is inevitable risks, no?
I agree.
Like, imagine if you would do it even without the whole intrusion, you would still run the same risk, according to the literature, no?
Yeah, I agree, and I know that is a big discussion about implants in aesthetics only.
And actually, let me just add one more thing. Remember that we started at a class 2 and we ended as a class 1, which is, I think there's a higher chance that as a class 1, having contacts in the palatal of those teeth, there will be a less of a chance of having, again, an extrusion of that area, as opposed to being a class 2, where, again, you could have no control over how these teeth extrude. I think it's a very important aspect of this case that we finish with contacts in the palatal of the frontal area.
Perfect. Yes, and I think she goes is about 30 days a day. You have to start with your work. You can't wait till you're 60, then you don't need the smile.
Yeah, true. She got married this year, so
yeah. There's a question from Whale Ed. Welcome here to this webinar. Congratulations to this beautiful teamwork.
Hello, Whale.
Yeah. Okay, I know you can sleep good tonight. to get congratulations on all these speakers is really an honor. But he's asking, how can you predict the impact of the intrusion treatment of the facial architecture?
You cannot predict in let's say you cannot put your hands on it. You cannot really, there's no actual tool to do it. I mean, there's no software to simulate it facially. This is just things that we know from experience, and we have been I learned a lot from Johnny, all these things, and for me it made a lot of sense in this case. The idea that first of all, the intrusion is centripetal. So this means two things. You're going to have the flaring, and because also in the molar area, the crest widens, there you're going to have the buccal corridors improve. Then you're going to have the vertical reducing, and you're going to have the auto rotation. So these things, they will happen, but there's not like any way to visualize it. The only way that basically, the tool that we are using in this planning is actually a setup. But the setup is simply right now we have to imagine how that will impact facially and just use our experience for that at this moment in time.
And by the way, that is the point that's why we didn't place the implant in the beginning of the treatment, because it's not 100%
the beginning.
The beginning. That's why we didn't place, because it's not 100% predictable. You don't have like a software to say, okay, we are going to impact 8 millimeters and everything is going to be exactly like that. So works very well in this kind of patients that we can move vertically, not like forward or back, because this is something that it's a limitation of a skeletal anchorage. It's like impossible to put all the maxilla back using skeletal anchorage. In these kind of cases, you need to use orthognathic surgery, but vertically can works very well. And of course, you need a very good ortho to manage everything.
Gustavo, there's a question for you as a surgeon from Mirren. She's asking you, what is the limit for flapless gingivectomy? You mentioned something about 1.5 millimeter.
Yeah, I think 1.5 millimeter, I think for me is the limit. When we have more than 1.5 millimeter, in my opinion, flap surgery, it's better. You can control better, and also the result with the osteoplasty, it's better for aesthetic result. So usually when we have like around 1 millimeter and the anterior zone, we usually have, as Florin said, the problem normally is the premolar area, molar areas. Then we prefer to open flaps, but normally 1 millimeter, 1.5, it's okay for us for flapless growing thing.
There's an interesting question for the prosthodontist. It's from Tim. And he's asking you, do you think that the motion tool using the patient's movements is really making a difference, or just nice to have? I think perhaps you can get one sentence.
Yes.
How did you find the right position for your lower jaw to move this? But I think this is an interesting question. I don't think that this is just fancy and it doesn't help anything. I think this is the way function should be done. To get all information you can get. So, Florin, what do you think about that?
Actually, this is a nice use case for this. So first, to answer the question, and then I will take a little bit of detail. So this tool scales with the complexity. The more complex the case you're treating, the more value you will get out of it. Of course, if you're doing a single molar or a quadrant, in quadrant dentistry in terms of, as a day by day, then of course your value will be less. So you should ask yourself the following question: am I doing a lot of full mouth rehabs? Am I planning to do a lot of full mouth rehabs? If the answer to any of those questions is yes, then you're going to get value out of it. Of course, like I said, in a single molar or in a quadrant where you don't change occlusion, of course it's not going to have as much impact. Now, to answer the question here is pretty much whatever we design, even though we design most of the things in a static position, will go into cycles, millions of cycles of function, whether we're talking about speech, mastication, or whatever. So I think it is very important to consider this. Of course, articulator can technically is doing the same in terms of projecting 4 cycles of motion. However, in a scenario like this, the whole value proposition was different, was the idea of the fact that the patient's function was physiologic. So I tried to preserve as much of the patient function as I could possibly have. Now, when you use an articulator, you're always changing the functional envelope. The alternative here was to use the pure motion, and as opposed to using an articulator, I would place the new structures in the existing functional envelope, respecting the existing cycles of motion, which is a different approach. It's like the other pole, if you want. Now, if you ask me about the lower jaw, there's a nice way to record. For example, here we opened in centric relation, and you can very easily record centric by manipulating the patient as you're doing it as a motion, because that also will generate like the hinge axis of that rotation as you manipulate. So we are trained to do it in static from the analog because we need to record one fixed position. But when you do it in motion, you need a rotation because you need a theoretical hinge axis. Okay. And what this technology can do can transpose all the motion from an existing axis to another, which is something very nice in case like this.
There's a fitting question to that from Golam. He asked, did you have a temporization phase for this patient before?
Yes. Yes. Do you have pictures in your presentation, Gustavo, with the PMMA?
Let me see.
Yes, we did. We had milled PMMA, which was technically speaking the exact same design as the final. Simply you mill it, that's your validation for what you're going to do as a final, and that's a very nice multi-layer material, which is high polish, very little plaque retention, easy to use, was quite easy to bond. You can see this is, for example, the PMMA.
Yeah.
And that's the ceramic. So it's the same design, the difference is in the optics. And there's a difference in the scope as well.
How long does the patient wear these provisionals?
How long? Just a matter of logistics. Or if you have a healing objective, then there are 3 reasons. 1, do you have a healing objective? Then it's usually about the soft tissue, and then can be up to 90 days. Not the case. 2nd, do you have a functional objective? Do you want to test drive something? Was not the case here either, because we were quite confident in just, again, we have a physiologic function that we just want to preserve, and we could easily see the second that we designed, once we had everything fit in a nice way and feel in a nice way, there was not so much to question about it. And the 3rd reason about provisional is simply logistics, okay? Which means just have something so the lab can work on the finals. Was just I believe in a few weeks, 2 weeks, I believe, till the ceramics was done.
Yeah.
Okay. For me, I see the time is ticking. It's already 8 o'clock, and I think we could go on because it was really a perfect lecture. It was very nice. It was just like having a cinema evening. This was the reason why we have this gin tonic, to enjoy these cinema evenings with you. And I think we answered mostly all of the questions, and there could be a lot of questions. And I thank you too to give you our wisdom, to share the time with us. And I think you two have to work for today. Gustavo, it's 9 o'clock. No, 2 o'clock in the afternoon now. You have to. For us, it's over for today, and I'm happy to see you all in 2 weeks. Christian, perhaps you can say something about the next webinar, which also will be very, very interesting.
Yes, first of all, I also like to thank you very much. It was, me as a lay person listening and watching this is always great how fantastic our job is and how fantastic your job is. And it's just so much fun to see what can be done nowadays in dentistry in terms of aesthetic, but also in terms of function. So thank you very much for your time. Excellent. So next week, we're going to have, in 2 weeks, we're going to have Vincent Fema, Irina Seiler, and Bjarne Petersen, and they're going to showcase their new publication. And we have all three of them, and we're going to talk about their fixed restorations. Yes, Chris has an example of it. It's a fantastic book, and it was a pleasure working with them. And it's an abundance of knowledge that obviously is not being possible to be packed in 2 hours. I'm out of focus. Here we go. So looking forward to that. So they share a little bit about their knowledge. So yes, thank you very much, Chris, Gustavo, Florin. Thank you very much. And I'm hoping to see each of you soon in real life somewhere, preferably in Brazil. I think it's the nicest place to be at the moment. So yes, enjoy your afternoon, your evenings, and the rest of the day. Chris?
Bye to everyone. It was nice to be together with you again.
Yes, thank you very much.
Pleasure for us as well. Thank you. And
yes, also visit SmileCloud. It's fantastic. It's a tool that you guys are working on. There were a couple of questions how to communicate and how to work long distance. This is a perfect tool to do that. I put the link in the chat.
Yes,
SmileCloud.
I think this is something I want to say. You know, SmileCloud is something Florin invented, and every other speaker would make every second picture of the SmileCloud that everybody buys this product, and you were so calm and so quiet. And just showed some picture, but it's a really great and perfect tool, and I kind of recommend everyone. There are some videos you also can look on YouTube, but Florin, perhaps I know there's a very good video of SmileCloud where you just can see the what you can do with it. Where can you see that? Perhaps say one word to this, because
I think there are on the blog on SmileCloud. So thank you, Chris. I never like to be commercial in any scenario, even if I have the possibility. It's just I'd like to not abuse these things, but yes, it's something that is basically a backbone of how we have been working in the last years, because it's a simple, let's say, quality of life in terms of communication and in terms of design, because this is all inspired from industries that all around we see people need to work in teams, and most of the time they have like specifications of what they do. We don't have specifications. I mean, we have treatment plans and stuff, but generally we have design, and that's the whole point. There's this idea of working around design. That's because at the end of the day, that's the goal of every treatment team in every case.
Yeah. And Florin, just to mention something, and if I can take the opportunity, we had just 1 hour to discuss like many different things, many specialized things. And if you want to see more, we are going to have a course together. In November, we have a 3-day course, so we can discuss deeper, like the implant workflow with the soft tissue surgeries, and all the digital workflow.
And gin tonic. Remember, there's also the gin tonic part.
And is it in Brazil?
Yeah, it's going to be in Europe, in Romania.
In Romania. Perfect.
Yeah.
I will be there.
It's a pleasure, Chris. It's from November 18 to 20.
Okay.
So 3 days.
I'll prepare the gin.
Yes.
I actually looked for Romanian gin before we had, because I wanted to show up with Romanian gin. I only found one, so I didn't order it because I wasn't sure if it was good or not.
Yeah, well, I'm gonna make sure we have a good one. Probably it's not gonna be Romanian, but it's gonna be good.
But the Romanian wine, I learned it's amazing.
Yes.
Yeah.
It's good. We test them all. So thank you very much. So
thank you.
Thank you so much, guys. It was a pleasure. Thank you.
Bye.
Bye.
Bye to everybody.